Hello everybody, I'm back. Dr. K.K. Agarwal, President, Heart Care Foundation of India and Confederation of Medical Association of Asia and Oceania, and past National President, Indian Medical Association. And you are watching Med Talks with Dr. K.K. Agarwal, 136th non-stop episode on COVID-19. Let's have the headlines today. Ever since we have started Med Talks with Dr. K.K. Agarwal, the Med Talk viewership has crossed 1.77 million so far. COVID positivity rate declines from 15 to 5% in Delhi nearly after 2 months. The Rajasthan government is going to re-emphasize on contact tracing, containment, and intensifying testing to contain the spread of the virus in Jaipur and Jodhpur. India continues to wait for the Oxford AstraZeneca and Bharat Biotech shot against COVID-19. Med Talks feels India will get it within December. India will need 6 crore vials in the first 6 months of vaccine being available, shorter quarantine period of 7 days with a negative COVID test and 10 days without a test would work for individuals showing no symptoms after exposure, says the US CDC. It's a time to start our topic of the day, but before that, let's practice hand washing. So we take a longer acting hand washing gel and we say S for Seedha, U for Ulta, M for Muthi, A for Angutha, N for Nakhun, and K for Kalai, and that gives you hand washing technique called Suman K. And then we take a longer acting spray to clean our areas, and we are ready for the topic of the day. As promised, today we have brought you we have getting you a special guest, Dr. Heidi Stensmyren. She is the president of the Swedish Medical Association. She is a consultant anesthesiologist and intensive care specialist in Stockholm. She is also the chairperson of the Swedish Medical Journal. She is the president-elect of the World Medical Association. Now today we have the president-elect of World Medical Association, and I represent the CMAO countries in Asia as the president. And we will be interacting on the Swedish model. Everybody talks about the Swedish model, where there is no fine if you violate any law of distancing or not wearing a mask, where even actively the government said don't wear the mask. Their job was twofold: protect the high risk and the elderly at any cost, and delay the number of cases occurring in the society, because you cannot make it zero. Let's listen to Dr. Heidi, who will be giving a presentation, and after that we will have a discussion with her. Dr. Heidi.
Thank you, Dr. K.K. Agarwal. I have some slides. Maybe we can bring up the slides. Thank you so much. I'm very happy to be invited to speak. Sweden has a self-picture of having a system for all, full cover, medical cover, good health care. So that's the self-image of Sweden. And this COVID-19 pandemic has made us very humble, because we have failed to protect the elderly, and we have very high numbers of deaths. And what we also see, we see high numbers of other symptoms, especially in physicians, but also the rest of the population, like fatigue, heart rhythm problems, lung problems, and so on. So I will talk a little bit about what we experienced this spring and our lessons learned. Expensive lessons. So it can take, and I myself this spring went into the ICU and worked with the COVID-19 patients during the spring. So I can take the first picture after this one. So here you see, I just brief from start to put the situation right. You see in the red color there is Sweden in Europe. So we are a fairly big country, but we only have 10.23 million inhabitants. So the population is small. And here's the world picture. We're a small population in Europe. And by today, we have 6,972 deaths in COVID-19. That is far, far more than our neighbor countries. And normally we have very tight bonds with our neighbor countries, very tight trades and travel. Now we are isolated. And that's not only because the borders are closed and we have social distances. It's because our relation to the neighbors are not so good at the moment. Because we have a much wider spread. We have the incidence of 613 per 100,000 inhabitants. That's far more. That's like 6 or 7 times more than our neighbor countries have. So I can take the next picture. So here you see again, if you see in the middle, right in the middle, where the red colored in, and all neighbors have lower numbers. So we are normally, and that is a country who's got a self-image of being very good in healthcare. So next picture. So also here, I took, it's interesting to see the numbers first, because sometimes we have done some things good, but the numbers are clear. So here you see the countries of some of the countries who have high numbers, like Luxembourg and Montenegro. Their Czechia is close to us, Belgium as well. But we, Sweden, have 68.47 deaths per 100,000. Makes us fairly high in the ranking, in the not so good ranking list. Next picture. So here is a picture from the subway in Stockholm at the moment. And maybe this picture is 5 or 6 days old. Now the last days they have put more harder restrictions a little bit on us. So, but it will be fairly like this. It's not packed, but too crowded, and there are no face masks. And we can say briefly, lessons learned, we were slow in testing, and we did not scale up testing fast enough. No one had the testing capacity from start. That's okay, but we were too slow. Other countries were in average to lower the R numbers, but when it started the R numbers to increase, everyone started to try to push down the R numbers, the replication rate. We, Sweden, we managed to get the replication numbers down after 58 days. The average in Europe was 30 to 34 days. So we were slow. Okay, so testing, contact tracing is important. Regional restrictions are important, what we see. That's what we have learned. We have regional restrictions, so we are not without restrictions. Prevent spread to elderly people and risk groups. We were early out and said we need to protect the elderly. Yeah, we failed. And the reason was we put everyone at home, all the workers for the elderly homes at home if they had symptoms. But many of them, and we paid for them to stay at home, but many of the people working with the elderly were paid by the hour. They had no employment. They could not afford to stay at home. So we also learned that physicians and healthcare workers are essential. So we had good results when we were pooling over to intensive care. So that helped us treat many. And we also need an increased national governance for healthcare, what we learned. This small country, 10 million inhabitants, have 21 different healthcare systems, and all of them were not coordinated. So, next picture. So here is from my intensive care unit, and from the spring until now, we have reduced the hospital mortality with approximately 50%. That is both in the ICU and the ordinary ward care. The numbers are a little bit different from hospital to hospital, but in average 50%. And we have looked into many of the reasons, and so, but we so far can conclude the anticoagulantia, early start, and high dose anticoagulantia and cortisone to push the inflammation down. That's the two main reasons we believe. And of course, we have learned to handle the respiration, and we have learned a lot. What we also learned that from start, we thought we would use the basic intensive care treatments and build up basic one outside of the hospitals in military facilities. But we learned fairly fast that to use our high-end facilities and expand them instead with lots of instruments and all the special things. And so rather than building out military facilities outside the hospital, so we used the really high-end ones. Okay, next picture. Okay, so here is Sweden, 21 different healthcare systems and very small capacity, each one of them. So every one of these healthcare systems were out on the international market to try to buy medication, pharmaceuticals, articles, ventilators, all the treatments we needed and all the protection gears. We were too small. We were competing against France with so many millions inhabitants. So we were small, and that we learned you have to to buy things on the international market. You need to be a bigger size, bigger scale, and we were uncoordinated. We also have the lowest number of ICU beds in all of OECD countries. In all of Europe, Sweden is the lowest. 5.8 beds per 100,000 inhabitants. That makes us, so we were starting way behind. We had to double that and we did double that in 1 week. So we were able to open up and start new. That was good. It showed that we do have the capacity to scale up intensive care. Okay, we also had lack of testing capacity, did not manage to scale up. And in some way, the authorities were not pushing for it. And why not? Okay, if you look at number 4 here in the one, we have regional self-governance, 21 different healthcare systems. All of these they were having their own guidelines and their own decision if to scale up testing or not. And they did not agree on things. So the government did not have the power to tell them to scale up testing. So despite that there was money, there was not being made. So we also had a shortage of doctors in elderly care and municipalities. They did not have doctors, but all the doctors were in the hospitals. And Sweden has a very low rate of family doctors and GPs. So if you look at, in comparison, our neighbor countries like Germany, France, UK, they have high numbers of family doctors who knew the communities and could communicate with the population and the elderly easily by phone because they knew them, but we did not. So we have a lack of GPs in the country. Next picture. Okay, Swedish strategy. Here, look at the GDP. So economy is part of the strategy. So we look at the whole society, not only COVID. So this was the drop in our GDP. It dropped very, very much in Q3. We are exporting dependent country, and without the economy going, there will be no welfare. So we try to have the economy going. We also kept the schools open. because you can have the click the next button. So and why was it so click the next one?
Next, yes.
Okay, yeah, there, thank you. Okay, first one, declaration of a state emergency is not possible in peacetime. So someone said we should start a war against Norway, and then we can have a declaration of state emergency. But that was a joke, of course. But Sweden cannot declare state emergency if it's in peacetime. That was important. Even if the government wanted to, they could not. Next one. Restrictions implemented as official recommendations. So when the government were not empowered to make restrictions, they make recommendations. We do follow recommendations, but of course, not as much as strict restrictions. Next one. Restrictions that could be endured for a long period of time. We said early, this is going to take time. If we have too tough restrictions, people will not be able to follow them for maybe 1 or 2 years. That could be debated, definitely. But that was the aim, not to have too high restrictions. Next one. And balance the needs of public health and social economy. Because we saw that we have a drop in the rest of the healthcare system. We need to keep everything up. We need to have cancer treatment, cancer screening programs going, and they were all going down. So we tried to keep everything going despite COVID-19. We also kept the schools open because we say if you close the schools, that's going to be bad for the children who will not get their education. Or maybe women have to stay at home to take care of children, because that's a gender perspective in that. So we kept all the schools open. Next one. And herd immunity was not official part of the strategy, but it can be debated if that was discussed. I know. So we have kept the schools open. Some schools are closed, but more for older people. Universities are closed. Next picture. Okay, I just wanted, this is interesting for the first wave. So if you see the upper picture, that's the incidence, that's the tracking of COVID cases. Okay, so February to August, and the numbers are difficult to read, but we were a slow start. Our tracking and tracing and diagnosis were late on, because the next picture you see, number 2, that's the admittance to intensive care. So they were directly in intensive care before we had a good track of diagnosis and testing. And also the picture, the last one, the number 3, the deaths. They came before we had the testing capacity up. And if you don't test, you don't know what you're working with. Well, you do experience it, but that was a severe lack. But that our testing, and we are still waiting for testing. Waiting times to get tested in Stockholm today could be 4 days. 4 days. So that's of course a lack. Okay, next picture. And press next. It spread to elderly care homes. 50% of all the deceased in Sweden are in elderly care homes, not in hospitals. Okay, number of ICU beds was too few. Successful rapid increase. Okay, next one. Cancelled surgeries, major backlog of treatments. We have 100,000 surgeries being cancelled. So that is not good. We are doing the surgery for the cancer treatments, but our cancer screening programs are lacking behind, which means we are not detecting the cancers. So there will be major problems coming up soon. Oh, and we have a reduced inflow to primary care and emergency care. And where are them? Here they are at home and sick. So there will be major problems down the line with this. Next one. And we do have an increase in digital healthcare. And here we look a little bit to India, because India is very exciting. You're very good at developing new techniques. But we do have a rapid increase in digital healthcare. And we now the doctors are running them more. They are not nice to have, but they are good ones, good new ones. Okay, next picture. Okay, here again, so is this, I'm not going to show you too many graphs, but it's increasing a lot again, development over time. So we had during summer, that's in the middle, it went down, and then it goes up again in the deaths. And by today, 6,972 deaths. So we are high numbers. Next picture. So new cases day by day. So here you see during April and June and August, we were quite happy that the numbers were low, but we were expecting a second wave. This is the time of the year where we normally have increased infections in Sweden. We have the flu coming in and other ones. And as you see now, we have COVID. The numbers are up and up and up. They are still rising. The new cases in hospital from yesterday to today was the same. So we hope that it will be stabilizing. But during November, it has been going up every day and more. And we are almost in the numbers of this spring, of the first wave. Not entirely, but maybe 65, pushing 70% of all the numbers we had in hospitals in the spring. The deaths are not that, it's not that high mortality rate in the hospitals because we treat them more rapidly. We have learned to treat them better. But we also see rising numbers of other symptoms and late COVID problems, like, as I mentioned from start, fatigue, heart problems, respiratory problems, and so on. And that is very worrying. So next picture. Yeah, that was the pictures. So that was from Stockholm today.
So I want to come back to one thing, and that is if I want to share the pattern. So this is the pattern which is occurring in the whole world. I'm not talking about Sweden or India. If I say globally, there is only one wave. Okay, and there are three peaks. This is a global picture. So there is only one wave, first peak, second peak, and the third peak. And globally, if you see, the mortality patterns are dependent upon the number of cases. The mortality was high initially, and then it is dependent on the number of cases. We can see three different distinctive patterns if you see the whole world.
Yeah.
Europe, all European countries are saying a second peak, but with that peak, the mortality is reducing. If I see all European countries, the second peak or the second wave, what you call, in the second wave, the mortality is low.
Yes.
Okay, whether it is UK, whether it is Sweden, Germany, except for Russia. In Russia, the number of cases and the mortality are parallel to each other. I can just show you the Russia, if I can. So if I say is Russia here, so if you see Russia here, Russia, this is the number of cases, and this is the mortality. Same graph. Okay, if you see Sweden, this number should have reduced. Then there is another pattern. We are seeing them in China. We are seeing them in China. We are seeing them in Korea, Hong Kong, Singapore, where mortality is very low from start. From start, the mortality is very low. Hong Kong, South Korea, China, then these are the countries where mortality is very low. Then we have India, Bangladesh, Nepal, Malaysia. They all are following the pattern of Russia. That means as the number of cases are increasing, mortality is increasing. Number of cases going down, mortality is going down. So we are having three distinctive patterns. The European pattern, where the number of cases are increasing, mortality is going down. And then we have Russia and Indian model, where the number, including South Africa, Belgium, everywhere, the number of cases, mortality is constant. It is not going down, it is not going up. It is a constant mortality of approximately 1%. And then we have in North America, where Mexico behaves like India and other countries. But other North American countries is, that is Canada, that is USA, they are behaving towards European countries. So when being a president-elect of the World Medical Association, I thought that we are trying to see three distinctive patterns. So one pattern is, I says, Asian countries towards Singapore, Hong Kong. And when I spoke to Singapore and Hong Kong in the same show, and then they says in their country, they don't see the role of anticoagulation. They says in our country, hypercoagulable state is not there.
Oh.
Okay, so they don't have protein C deficiency, protein S deficiency, factor V Leiden deficiency. So they have less of inflammation. They have less of thrombosis. So therefore, their mortality patterns are very low from start.
It's very interesting.
Now we are coming back to Europe and North America. They have 5% of their population have hypercoagulable state. Either they are factor C, factor S, 5 Leiden, where inflammation can precipitate secondary hypercoagulation. So these countries, there was a very high mortality before, and with the introduction of early anticoagulation, they have been able to reduce their mortality to true mortality, which is very low. And in other countries, which I am talking about, they don't have so much of hypercoagulable state. So their mortality are staying with the number of cases, and that will be approximately 1%. So for my analysis on behalf of Confederation of Medical Association, we have come to conclusion in those countries where hypercoagulable state is there in the society, you need early and intensive anticoagulation. Even in our country now, we have seen the mortality can be further reduced if we give them anticoagulation early along with steroids. So low-grade steroids with oral anticoagulation. I'm not talking about even injectable at home, which can be dabigatran or which can be rivaroxaban. So I'm not even talking about low molecular weight heparin. So if we institute them NOAC, which is newer oral anticoagulates, the mortality can be substantially reduced. So in those countries like Europe and in North America, where hypercoagulable state is prevalent in the society, early anticoagulation will further reduce the mortality. That's my CIMAO analysis on this particular thing.
And our numbers support that analysis. Early anticoagulant treatment and early cortisone.
Absolutely. I am even going to the extent, like in every case of acute myocardial infarction, we give them 300 milligram of chewable aspirin. So I'm even recommending that at the time of diagnosis, give them an aspirin chewable and start them on either dabigatran or rivaroxaban or apixaban.
We have similar regime here.
Good. So let's have one question because the time is up. Let's have Suresh Gupta. Do you want to ask anything, Suresh ji?
नमस्कार सर, मैं ये पूछ रहा हूँ, मैं 28 दिन बाद मैंने ब्लड थिनर बंद कर दिए थे, अभी विटामिन सी और डी ले रहा हूँ, कुछ और लेना है या नहीं सर?
So Sureshji is asking that I have recovered from corona and my 28 days are over. How long should I continue oral anticoagulants? So what is your regime in Sweden? How long you continue?
I'm not sure. Sorry, I cannot answer that. When I release them from intensive care, I know they normally continue for 2 weeks, but I guess 28 days. I guess that depends on how the condition is, how the health condition is.
So सुरेश जी आप बिल्कुल ठीक हैं, मैडम भी एग्री करती हैं 28 दिन आपको एंटीकोएगुलेशन देना चाहिए और now you can continue on ecosprin for some more time because of your age you can continue for low dose aspirin for at least for 3 months but anticoagulation you can stop.
इकोस्प्रिन में ले रहा हूँ सर, इकोस्प्रिन ले रहा हूँ मैं.
Very good. So I've asked him to stop anticoagulation and continue low dose aspirin because of his age and other risk factors. So Heidi, that was wonderful having you and sharing your experience. I will make sure we meet the CIMAO meeting every Saturday. So I will have all CIMAO countries see this show on this Saturday in the morning. I will have your 20 minutes presentation to them. So all the countries in CIMAO countries will see your talk on this Saturday at 9:30 a.m. Indian time. So let me thank you for being here with us. Anytime, whenever you need us, we are there. The whole CIMAO countries are for your support. And when you take over, best of luck. And by the time, if travel restrictions are not here, we will love to host you in India.
Oh, thank you so much. I am following your talk, so I'm very happy that what you do. I find I use that when I'm teaching and speaking here in Sweden. So I'm going to thank you for that. I have given the recommendation on face masks in the subway and other places where people gather in public spaces. But you can see if we can convince the authorities. Thank you so much, KK Agarwal.
Thank you.
Thank you. Great. Thank you.
That's all for today. Thank you, Heidi. And that's all for today. We'll be back tomorrow, 7 p.m. with another show. Keep watching Med Talks with Dr. KK Agarwal. Goodbye. Thank you. Namaskar.
Bye.